please. Next slide, please. Somebody said they would forward this. Okay. So first of all, I hope you are all well. Stay safe and healthy and get your shots. Next, please. The topic of this talk is osteosarcoma. Thank you. So I had started out with Osteosarcoma Epidemiology. We have an incidence which is low, 2 to 3 million per million per year. It's a typical tumor of adolescence. The sex ratio is males to females about 1.4 to 1. And the site is the metaphyses of long bones. Now, all of that would be no problem. You would amputate, but the tumor tends to metastasize. And as you see in the next slide, it's from our primary metastases paper. It's usually the lungs where osteosarcoma goes to, sometimes the bones, and rarely other sites. Next, please. You see here that the closer you look, the more you find. So with the old techniques, you thought that primary metastases only existed in about 10% of patients. We're now up beyond 15% and beyond 20-25%. So you cannot just compare localized osteosarcoma now with localized osteosarcoma 20 years ago. Oh, you will not compare the same diseases. Next, please. The standard approach has really not changed in osteosarcoma. You do your imaging, you do a biopsy, you find the diagnosis, then you give 2 to 3 months of neoadjuvant chemotherapy, then you do surgery of the primary tumor, and afterwards you give another half a year of chemotherapy plus surgery for any primary metastasis you might find. And the drugs which we have used have also not changed much since the early or mid-80s. It's high-dose methotrexate, doxorubicin, cisplatin, and sometimes ifosfamide. The benefit of additional agents, you can really discuss a lot there. Next, please. What do we get with this kind of chemotherapy? This is from a meta-analysis of real data. You see that about 70% of children are cured. If you're a little bit older, you do a little bit worse, but still about 65%. Next, please. Next slide, please. Of course, not everybody has the same chances. Here you see from a meta-analysis of our own that patients with typical localized limb osteosarcomas do much, much better than those with axial or metastatic. Now, why is this? Next, please. You see as an example the primary metastatic osteosarcomas, which had complete surgical remission here in green, against those which did not have complete surgical remission. And you see you have a fair chance with complete surgical remission. You have no chance if you don't have complete surgical remission. Next, please. The second prognostic factor, which we found and others found, is tumor response to neoadjuvant chemotherapy. Good responders, usually defined as those with less than 10% viable tumor, do a lot better than poor responders. Next, please. Now, are things getting any better since the early 80s? Next, please. You see that things have really changed for surgery. In the old days, on the left, In yellow, people were amputated. In red, people were amputated. In green, you see the rotation plasty, and less than a third had limb salvage. Nowadays, on the right, you see that up to 90% of patients have limb salvage. So there has been a true advancement there. Next, please. Unfortunately, as you see here, in the EU and in North America, things have not changed since the early 80s. The advent of chemotherapy was a huge prognostic achievement. After that, prognosis stayed the same. Next, please. Now, let's try to improve chemotherapy. First of all, does it matter how many of the effective agents, methotrexate, doxorubicin, cisplatin, ifosfamide, we use? Next. A very nice meta-analysis by Jacob Eninga from the Netherlands. On the left, he looked at studies using only 2 of those drugs on the bottom against those using 3 of those drugs on the top. A clear difference. On the right, you see studies using 3 of the drugs or all 4, and there is no difference anymore. So we have 4 effective agents, and if we use 3, it is probably good enough if we use them as I described before. Next, please. Now, might results be improved by increasing the dose of chemotherapy or dose intensity? Next, please. This is from a randomized British study, the predecessor to Euromos. They used GCSF to compress the interval between chemotherapy cycles and succeeded. So they used the same chemotherapy with or without GCSF. They did not succeed in reducing the response rate, as you clearly see, the relapse rate. Next, please. Also, high-dose chemotherapy in a non-randomized setting from Italy and Scandinavia. They used double transplants here in red and in green, the controls, no high-dose chemotherapy, absolutely no difference. So that's not the way to go to increase dose intensity. Next, please. Now, might results be improved by bisphosphonates? That's been looked at by the French in a sort of complicated study. Next, please. Next slide, please. Yes. Here you see in red the control group, and in blue there's a bisphosphonate group, so ladronate added to chemotherapy. And if anything, so ladronate did worse. So the recommendation is to not use bisphosphonates against osteosarcoma. The next, please. Then I showed you that the prognosis is much poorer for poor responders to chemotherapy. We want to improve the outcome. And if we want to do that and do some statistical calculations, we find out that we need thousands of patients, about 2,000 patients to prove that. So next, please. We decided it was worth it and went into a huge international cooperation. You see the countries here for international groups. Next, please. All patients received the same pre-op chemo with methotrexate, adriamycin, doxorubicin, and cisplatin, and then the poor responders were randomized to the same chemotherapy or augmented and prolonged chemotherapy with ifosfamide and etoposide. Next, please. Here you see it. Chemotherapy was 11 weeks longer and included high-dose ifosfamide and etoposide. Next, please. And here's the result. In red, the longer chemotherapy, augmented chemotherapy. In green, the standard chemotherapy with MAP. And after 2-3 years, you see no difference. So you only see that people looked later in the longer chemotherapy arm, but afterwards it was the same. So next, please. The toxicity of the augmented MAPI arm was higher. The non-hematologic toxicity and the secondary leukemia rate was higher. Next, please. Next, yeah. So the conclusion was that adding ifosfamide and etoposide to MAP is associated with additional morbidity and has no effect on survival outcomes. Next, please. Might results be improved by immunotherapy? A very modern question. There are several approaches. One is this liposomal muramyl tripeptide phenylethylamine. As you know, it is licensed in Europe based on an American trial. It is not licensed in the United States, and it got some very nasty comments by the FDA. We approached the company multiple times, but they're just not interested in another study. They don't want to know if their drug maybe doesn't work, so we don't use it. The next, please. We did randomize another drug, liposomal interferon alpha, in the good responders of the URAMUS trial. So after MAP, good responders were randomized to continue with MAP or to receive interferon after MAP. Next, please. Here you see it. The interferon was given late. The randomization was rather early after surgery. Next, please. And here you see the results with the interferon in orange and without in green, and there's no statistical difference at all. Next, please. So the conclusion would be that our evidence does not support adaptation of postoperative chemotherapy based on histological response. That is a sad but true finding. What happened then? Now, URAMUS ceased recruiting about 10 years ago. Currently in Europe, in the URAMUS, the 4 URAMUS groups, they don't have GCP trials for first-line disease. The French have French trials, which are very different from everyone else in Europe and probably the world. The Italians have non-randomized trials, which I think don't tell us much. So we don't have good GCP trials. We have some registries open in some countries, including our own COS registry. Next, please. There are some phase 2 trials with tyrosine kinase inhibitors, lenvatinib. We have trial of metronomic chemotherapy which includes osteosarcoma, and the Italians are looking at gemcitabine docetaxel versus ifosfamide for relapsed patients. We'll have to see if anything comes out of any of those trials. Next, please. Next slide, please. Yes. What we're doing in Germany presently, not limited to osteosarcoma, but including osteosarcoma, is that we enter all our relapses, that we analyze them molecularly, and that we try to find targets for those relapsed malignancies. In osteosarcoma so far, it doesn't seem to work very well. They change so much. They have many genetic alterations, but none which, or rarely alterations which you would target. Next, please. So our group, what is that doing? We have our registry open for all osteosarcoma patients and patients with related diseases. And we are starting to collect biological material of all entered patients. The question is real-world efficacy of treatment in 2021. And of course, we offer consultation services for all registered patients so that knowledge about osteosarcoma, knowledge about difficult situations can be accessed by anyone from anywhere in Germany, Austria, and Switzerland. We've started this registry with a question, and the question is about individual tumor predisposition. As you know, osteosarcoma might rise after certain syndromes, but it seems that tumor predispositions are more common than previously thought. And we also collect this tissue to look at analyses for different questions. Next, please. So in summary, osteosarcoma is fatal with surgery of the tumor alone. It is fatal with chemotherapy alone, but we have success with intelligent combinations of both. There has been little improvement now in osteosarcoma for almost 40 years, at least as far as survival is concerned. And there have really been multiple prospective studies, but none has given us a breakthrough. We need innovative therapeutic options if we want to move forward. And even after 40 years of no advances, we're not giving up. We do it. Next, please. Thank you. And please, all of you, get your shots and stay safe.